choices in our life choices. When my new friends Sudhi Rao and Mark Perlmutter asked me to give this talk, I said, sure, honored. How much time and how many people? Sudhir said, oh, we have hundreds of members, and take all the time you want, an hour, whatever. I said, okay. I prepared an hour's talk. And then I pretty quickly began to receive these emails from this Maggie Kearney that made it clear that I had 25 minutes, no more, no less. Wanting to be a team player, I shifted gears, and so my plan is to try to stick as close to 25 as possible. I hope you don't mind if I refer to my notes, keep myself between the lines. I heard a story once of first grade classroom, and the good teacher tried to program into each week a little time for her students to express themselves artistically. One Friday, she handed out paper and crayons to every student and told them that they have a half an hour to draw whatever they would like to draw, anything that came to mind. And then she went from student to student, giving pointers and asking questions. She worked her way to the back of the room where a little girl was working away diligently on a drawing. She said, Hannah, what are you working on? Hannah was concentrating, didn't look up, and she said, I'm drawing a picture of God. The teacher took a half step back, not sure how to give any pointers on that. She said, well, Hannah, that might be a little difficult because nobody knows what God looks like. Hannah still putting final touches on her creation and still not looking up. She said, well, they will soon. Now, unlike Hannah, I would not suggest to you what God looks like. In part, that's not what I've been asked to do, but mostly because I don't know what God looks like. I've never seen Hannah's picture. I have, on the other hand, spent most of my adult life, from time to time, listening for the voice of God. And when I thought I had it best sorted as best I could, to try to do what I was told. I'm pretty sure I haven't gotten it 100% right, but somewhere in there is the why behind the what of what we do at Neurological, and that's what I've been asked to present. The why behind what has to do with the voices that we listen to. I have been asked to present in 25 minutes or less the work we've been about for the past 35 years. Work of a Christian Mission Hospital and foster children's home, bilingual school, and other service-oriented outreach to the poor and powerless on the north coast of Honduras. So where do I start? I thought I might start with one of those stories you never can tell in a newsletter. I think of these stories as negative Ebenezer stones, the experiences behind you that you don't want to repeat, the exits you took off the interstate that lead to dead-end roads with closed gas stations, places you want to remember not to go back to. And here's how this story starts. About this time of year, 24 years ago, about spring 24 years ago, we were nearing our first anniversary in our lives as medical missionaries living in an obscure village, a little known part of Honduras, in the Departamento de Colón, in the country in Central America, on the edge of the jungle where the mountains fall off into the Caribbean Sea. We'd begun that work actually in the beginning of the 1990s, starting with the initial exploration of the country, then working my way through the Ministry of Health, looking particularly for acceptance and approval and direction. We began two different charitable organizations, one a U.S. 501c3 called the Cornerstone Foundation, The other, a Honduran charitable organization called Asociación Piedra Angular de Honduras, or APA for short. And somewhere in there we sorted out the where question and then purchased the first tract of land necessary. We built roads and bridges, electrical power supply, water sources, warehouses, workshops, guest housing, and toward the end of the 1990s, we had a shell on the roof of the hospital. No, the roof on the shell of the hospital. And all of that time, throughout the 1990s, while coming and going to Honduras pretty frequently, my day job actually was in a very busy surgical practice of general and vascular and thoracic surgery on the Gulf Coast of Mississippi. And all of that time, the plan was that we would be on the field in 2 years. And that 2 years took 10. Still, sooner or later, you decide you've cut enough bait, it's time to go fishing. And so in June of 2000, I moved with my beautiful young wife and our young children to the village of Calafate. And we quickly learned, I think in this photograph, that's Nate, he was 8 when we got there. Gabriel was 6 going on 7, and Hannah was 2.5. We were the only people that looked like that anywhere around us. We quickly learned that coming and going frequently is one thing. Going and staying is a very different thing. For instance, by the time that this story takes place, about 10 months into our lives there in Calafate, we had been robbed about 20 times. Most of these were petty theft, shoes, toys, chocolates left out on the porch, clothes left on the line, our kids' bicycles, no matter how many times we tried to find one. It was hot, life was hard. Our neighbors were poorly educated, clannish, not very welcoming. In short, by the spring of 2001, the bloom was very definitely off the roads. We lived at that time in a partly converted coconut warehouse on the edge of the Rio Bejucal. The Bejucal River takes a sharp bend right there before it crosses the bar and empties into the Caribbean Sea. So that on 2 sides of our house and property was the river, and on the other 2 sides was the village proper. We actually lived on the corner of the Parque Central. The village of Calafate in those days was sandy streets, maybe 1,000 people, 1-story buildings. Most of those 1,000 people, maybe 90% of the population, the primary occupations were fishing, subsistence farming a little further inland. There were a few ranchers that lived in town, a couple of shopkeepers, a handful of public school teachers, and a few government workers. Calafate, in all of its civic glory there, is the municipalidad, the county seat of the district. And that's the primary occupations for probably 90% of the population of Calafate in those days. But at least 10% of the population, as far as I could tell, their primary occupation was drug running, robbery, the occasional murder, and other general bad behavior. It was a pretty lawless place. Every couple of weeks you had to try to trek into town being the nearest city where you could buy groceries and maybe hardware goods. That city is the city of La Ceiba. And these days it takes about an hour and a half to get to La Ceiba. In those days it took 3.5 hours if you could get there at all. Calafate is still 3 rivers from the nearest paved road. And in those days, there were no bridges. So if you could get into La Sebe at all and you wanted to, while you were there, pick up a newspaper and see what was going on in the rest of the world, you'd be a little disappointed because instead of the rest of the world, you'd see mostly what was going on in the rest of Honduras. And as illustrated with grisly photographs throughout the newspaper, what was going on in the rest of Honduras was murder, because Honduras was the murder capital of the world in those days. If you read any of the articles, you see pretty quickly that kidnapping of children was common. So you can see that as a father and a husband, I could not help but see many strangers, most every stranger, as a potential threat to my family. Now, back in Balfate, at the end of one day when this story takes place, I'd come home from working at the hospital. Actually, in those days, it was more likely working on the hospital. We'd begun a 3-day-a-week clinic by then, but there was still a lot of construction work to be done. I came home tired, I recall. We had supper. I was happy to be with my family. After supper, I was making my way through this eclectic arrangement of rooms in these slides aren't numbered, in this coconut warehouse house that we lived in, to this kind of hidden door that gave entrance into the garage. Because in the garage we kept an old refrigerator, and in the refrigerator I had stashed some popsicles that I'd worked pretty hard in keeping in a semi-frozen state as a treat for our kids. And this would be dessert for the kids. So I pop out into the garage, and instead of popsicles in the refrigerator, I found 3 guys in the refrigerator cleaning it out. Both parties on either side of the refrigerator door were rather shocked to see each other, but they recovered about a split second before I did, turned and took off through the other garage door, the door through which they'd broken in, and I took off after them, with my every intention being tackling whoever I could get my hands on. But just before I could, they jumped the garden wall and jumped into the river and began to swim across. I stopped at the garden wall, kind of torn between going back and picking up the food that they jettisoned in their flight across the yard and continuing my confrontation. I was pretty pissed off, and so I chose the confrontation option and was yelling at them to come back, which of course they ignored. And so then I changed tactics a little bit and started yelling about the alligators that lived on the other side of the river, and they better come back because there really were alligators on the other side of the river. This just seemed to speed them up a little bit more. Really frustrated, I looked down at my feet and noticed this nice pile of rocks at my feet. And I picked one up and thought I would get their attention because they just weren't listening to me. So kind of overhand, I lobbed this rock out at these 3 frantically swimming guys. That seemed to just speed them up a little more. And about that time, this voice whispers in my ear, you know, you don't really care if one of these rocks lands on one of these guys. They have stolen from you. And so my firing for effect came closer, and the depth charges next to these swimming bodies from my rocks kept getting closer and closer until they got out of range and made it to the other side. I remember watching these 3 bedraggled teenagers pull themselves up into the mud on the other side of the river, leaning on the wall and thinking, what the hell was I doing? I was throwing rocks at hungry kids who were just stealing our food. I wondered about the voice that I had been listening to. And I think that that was the voice which Cain listened to. Now looking back, I can see that subliminally in those days, I was always on the defensive. I was scared about protecting my wife and children in a lawless place. I was angry that these guys had broken into my house right in my face when my family's there. I was frustrated that my command of the language was not powerful enough to control the situation. And I was offended that they would steal from me and mine what I worked really hard to provide for them. And so it wasn't too surprising to me, looking back, that as I listened to these teenagers splashing through the darkening swamp on the other side of the river, that I realized that the voice that I'd been listening to was the same voice that Cain had listened to, the voice that led him to murder his brother, led him to wander the earth alone, to die alone, with a God of his own preference, which was himself. In an earlier iteration of this talk that I could not deliver in close to 25 minutes, I spent a fair amount of time discussing one of what I think is one of the great philosophical dichotomies of our time, which is the distinction between the voice of postmodernism, the essence of which is Nietzsche's The Will to Power, and the enduring best voice of the West, which motivates us to voluntary individual self-sacrifice for the good of another. The conflicting voices that we listen to can motivate us to very different ends. The recognition of that is not new to humankind. It dates back thousands of years to one of the earliest written stories there is, the story of Cain and Abel. And if you're interested in that and would want to talk about that sometime later, I'd be glad to, but I don't have time to. You can find it in the 4th chapter of the book of Genesis. But in contrast to that voice that leaves you throwing rocks at kids that have stolen your food at the end of the day, most of the days for the past 25 years, and most of the people involved in those days in the past 25 years, I believe, have been animated more by the voice that motivated Abel. And that would be more like the day that follows, which was more like a day in the life of the work currently at Beaumont et Luz. Now, on that day, pretty typical day, which is just a few weeks ago, I woke up at the house that I built about 20 years ago, closer to the hospital, a little ranch there. We don't live in Balfate anymore. It's about 3.5 miles away. And we don't live in a coconut warehouse anymore either. This is our kids now are all grown and gone. They're professionals in the United States, but this is where they grew up. This is where they come home when they come home. In that house, I made coffee in the morning, did devotions, talked with Roseanne, my beautiful wife back there, and hopped on my motorcycle and took off for work. When I did, I stopped right outside the house, turned around, and took this picture. And I knew that I wanted to present the entire work in a day, so instead of turning toward the hospital, at the bottom of the drive, I took a turn toward the east and pretty quickly was at the Escuela Bilingüe del Camino, the bilingual school that Roseanne began about 20 years ago, when she told the teachers, those public school teachers back in Balfate that were her friends, that she would school along with our children, some of the village kids, give me some of your poorest and most promising. And 5 became 8, became 20, and over about 8 years she taught them with our kids. And then other teachers came alongside and were really great teachers and took some of the load off of her. And now, 20 years later, there are about 200 children there learning in 2 languages in 14 grades. And through the eyes of faith, we see these children as the future leaders of Honduras. It's a happy place for me, but I couldn't stay, I had to go to work. So I turned toward the west and continued on this terrible dirt, muddy road. It's not always terrible, but it was when Sujit and Mark were there. Passing through the agricultural work that we have, there in the palmeras and the African oil palms and cacao, our workers work to help the sustainability of the entirety. I also passed there on the north side of the road, this foster children's home called Casa Santuario, and there we have, for the past 20 years, taken care of scores of children who didn't have a home. This is still their home. A little further on to the west, I came to the gate of the hospital and backed up and took a photograph of the gate of the hospital. You can see that the sign on the gate there says Hospital Uno de Luz, Dios obra aquí, which is God is at work here. Now, we don't work there. We don't really see that as just a slogan or even a statement of faith that God is at work here. We see it really as a declaration of a truth that it really does, and it's also one that we need constant reminding of. Went on up the hill to the main hospital bodega and spoke with some of the construction maintenance guys about construction maintenance stuff. And then on to my own personal salt mine, which is the operating room corner. I knew that I wanted to present a kind of a day in the life, so what did I do that day? In these operating rooms, what did I do? I did a mastectomy for cancer, an emergency C-section, cholecystectomy, nailed a long bone fracture, a neglected femur from one of the public health hospitals, and what we call macheteado, a machete chopped guy that had divided all of his extensor tendons of his left hand and arm. In between those operations, I did probably a dozen consults with our bright and promising young doctors. Most of our young doctors are really great Honduran physicians who are very willing and eager and able to learn. But I also had occasion to go by the administrative office and terapia, the wound clinic, the laboratory, the chaplaincy, x-ray, the dental clinic, pharmacy, labor and delivery, enfermeria, the main nurses station. And everywhere that I went, throughout the hospital was packed with people, with human beings who were injured and ill with all kinds of maladies, the human condition. And everywhere that I went, they and their families were being cared for and listened to and counseled and prayed with and treated with dignity and respect. And everywhere I went, if I listened, I could hear this consistent, still, small voice calling us to voluntary self-sacrifice for the good of another. And I submit to you that this is the voice to which you will listen. The author of the Hebrews wrote, "By faith Abel offered to God a more acceptable sacrifice than Cain's. Through this he received approval as righteous, God himself giving approval to his gifts. He died, but through his faith he still speaks." Now I figured I would be speaking to a room filled with gifted people. I'm sure that I am. People who have most likely tended to make life choices and daily choices more often, animated by the voice that they will listen to. The quieter, steadier voice. It calls us to voluntary self-sacrifice for the good of another. And not so often to the strident, pernicious voice that pushes us with the will to power. Otherwise, I'd be speaking to a room full of very bright politicians or billboard lawyers, instead of to a room full of physicians and surgeons. I just wanted to remind you of the distinction, and to thank you, and to encourage you for all the times you listened to the right voice and did what you were told. Because, as the Apostle Paul wrote, through his faith, he still speaks. And so you. So thank you.
Please stay with us for a few more minutes. Open it up.
I don't know anything about spine surgery.
Okay.
But we can help you out if you need help.
How many hospitals were there in that? How many hospitals were there in that system? Was there only one hospital where everyone came?
When we started, and still, the answer to how many hospitals were there is zero, other than what we built. When we got there, this was had a lot to do with why the government directed us in this area. There was no health care. There were no roads. There was a path. There were a lot of people, but there was essentially no health care. And now we still are the only one. And we have, at first, we were the primary health. We were the only health care for our catchment area, which had 70,000 people in it probably, and now it's more. It's a referral hospital really for the entire country. 70% of our patients come from all over the country.
How's the radiology department there? Do they have basic machines and stuff?
Yes, we have digital radiography, and it's been a real upgrade from developing films and having to keep those machines working. So we have standard X-ray, and we have a couple of C-arms and a lot of portable, or several portable machines. So it's a DR system. I think that we're probably the only hospital in the country that is on electronic medical records and it's integrated with the DR. So I can look at any image on the computer. We don't look at films anymore.
How about CT or MRI?
We have CT and MRI in the nearest city in La Ceiba, and we send our patients there and they come back with the CT scans. We've certainly considered it, but to provide that kind of service, you don't just have to buy a CT scan, you have to have trained CT techs, you have to have designated room, you have to have the computers and the memory, and there's a lot behind the scenes of just CT image, and it's just not a direction we need to go, because there is someone in the country, people in the country that can do good CT scans and MRIs in the nearest big city, and we'll get them. Mm-hmm. Yes, sir.
Well, first of all, thank you for the inspiration and reminding us. I said this to my son in medical school, to remember the why behind the what. So thank you for that. In building, do the patients pay? Do you basically, I mean, obviously the board's provided amazing things for you to have this facilities. Do you have a lot of people that are sponsoring you, or is there something that the government's helping? I mean, how did he provide?
Mm-hmm. The answer to that in 3 points is the government. No, not at all. We don't take funds from government. They don't offer them. We don't want them. And they don't have them. Otherwise, they wouldn't need us. Yes, lots of donors, thousands. But we also early on determined, for a multitude of reasons, that we did not want to do this on a handout basis, that people deserved to take part in their own health care and not just be given it as a handout. And actually, I was asked that 30 years ago by the Minister of Health in Honduras, who's a really, I think, bright and different politician, who that was one of the questions when I first met with him was, do you plan to charge the patients? And I didn't really have a planned answer, but I said, well, I think something, we're not in the business of making money here, but of self-sustainability would be the ultimate goal, and that we think that patients should pay something for their own health care. And he said that would be good, otherwise you will rob them of their dignity. And that really stuck with me, and so we do. The hospital itself on it, not just for the hospital and the whole work, there are like 75 buildings in the work. That includes the school and foster children's home. You don't make any money on orphans, I found. The hospital provides for that for the most part on its basic level. It's pretty close to self-sustainable on a very basic level. The Cornerstone Foundation of the United States provides capital expenses, large equipment, projects, helps out in shortfalls, but for the most part, in Pampers and propane and sutures and everything that goes into running this kind of work, the hospital pretty much breaks even for the whole work.
I say that's covered. If you look up their website, it's covered beautifully in the website as well. And it's a highly successful group of people you just lectured to who've been through a lot of things in their lives, and you can see we're maybe a little curmudgeonly. We ask each other pointed questions at the end of it, and you can see what you've reduced us to, which is just basically silence and admiration. I do want to say, I would suggest humbly what this guy looked like, a little bit like that little person there down at the bottom on the left, happy, smiling, hopeful, and wishful. I do want to ask you, as I've gotten some gray hair, to think about, the voice carrying on in the future. I've done my best, and my residents, my future residents here with me to carry the voice on in the future. How do you carry on for the voice? Clearly, you've been the driving force through your wife and your family, been the driving force for this. How do you ensure that it's still there when you can no longer?
Well, trying to listen to that voice and put it in action over the years, the plan has, well, not the plan, but the reality has sort of shifted to that instead of 4 national missionaries as your primary professional staff, it's more than half now Honduran nationals, but very selective, not just employees, but special people that really want to give back to their people and share the better voice they listen to. So we have 7 young physicians right now that are Honduran nationals, 8, a couple of dentists, pharmacy. We have a lot of Honduran professionals now that make up part of the staff. And that's the future.
With no further questions, I will humbly present you this plaque saying thank you, and they say in the parlance, tough act to follow, but Dr. Raymond is going to do it. So, Razzie in here? Great, thank you. This is why you asked all those radiological questions. So now we're going to hear about the complications of spine surgery from a radiological perspective. Thank you very much for joining us for the Cleveland Clinic Foundation. We'll get you booted up. I visited, I don't know if anybody's here from the Mayo Clinic. I visited the Mayo Clinic a couple of years ago as a spine surgeon, as a neurosurgeon. And I just out of curiosity, I said, how many MRI units do you have? And the surgeon looked at me and goes, well, we have 52. He said, but he said almost embarrassingly, he said, but at any point in time, about 10 or 15 are down for surgical upgrades. Can you imagine a building with 52 MRI? I didn't even venture to ask how many CAT scans and how many other radiographic studies were available. I mean, in embarrassment of riches, right, that we have in this country that we built. So keep that in mind. Thank you, Dr.
Hello everyone, nice to meet everyone. As they say, surgeons fix the problems and radiologists find the problems. So let's get started. I'm going to be talking about postoperative complications of spine surgery. I'm trained in both neuro and musculoskeletal, so spine sort of meets in the middle, so one of my favorites. So let's get started with some of the issues that we may face, post-operatively. This is what we'll do, just an overview of how this talk is structured. So we'll talk about, some of the indications of spine surgery, followed by early complication recognition and the role of imaging in diagnosis and management. So what are some of the indications of spine surgery? As you all know, the most common is degenerative, of course. Disc disease is the #1 culprit. Then, obviously spine deformities. So I also trained at hospital for special surgery, and we would get really, really crooked spines, whether they're congenital or acquired or what have you. And some of those cases seem really, really difficult. Traumatic injuries, of course, a lot of us are at level 1 trauma centers, and you see these bullets going through and through to the cord, and those could be urgent indications for surgery. Infections, and a referral center like Cleveland Clinic, we do see a lot of tumors as well. And then, of course, field conservative therapy is the #1 thing. Once all the insurance stuff is cleared, then the only thing to do is to go in and take a look. So I would say early recognition is the key. The reason why I was asking so many questions earlier on, because for example, acute API. Our medical practice has changed with CT scan, and obviously now with MRIs. It's very hard to diagnose some of these things without good imaging establishment in place. So I can't even imagine surgeons taking the risk to open up the patient without having a roadmap in hand. So I always think of radiology as a collaborative department where we try to make your life easy, give you a roadmap, give you a navigation system, so you are successful, and in the end the patient is successful. So I would say early recognition is the key, and for that imaging is the key. And complications can range from very minor complications to life-threatening complications, right? Timely intervention is important. First you have to find out what's wrong, and then you have to intervene as quickly as possible. Some of the times, the patient is discharged, they go back home, and there is delayed diagnosis. That just makes things worse. So we don't want to do that. And sometimes the clinical symptoms are very non-specific. Patient may be a poor communicator, and at that time your best friend is your radiologist. So feel free to call us and get that imaging done and find out what's going on. Like they say, whatever you can measure, you can tackle, but you need to know what's going on. So last night at the dinner conversation, I think we all were making this joke about operating on the wrong side and how common that is really. So 3 commonest causes of poor result, obviously, it's not that obvious, but in spite of our double, triple checks, still is common things are common, and wrong level is still the most common cause for errors during surgery. So I have to be cognizant of that, and hopefully AI will help us with this as well. Some of the basic complications of spine surgery we can think of, the worst scenario is you lose your patient, or they may have like a long-standing neural deficit from nerve injury or maybe just local anesthetic effect. And then other things like, DVT or PE from poor ambulation or PT after surgery, which is equally important. And then some bad complications like, vascular injuries, bleeding, which may be not detected in time, dural tear, and obviously infections, right? We always get informed consent for that. The imaging modalities that we have available, we have many more imaging modalities now. We are in 21st century, so basic things like X-ray, ultrasound are very easy and very portable. So if you are in a rural area, that's easy, and you guys can possibly read those yourself as well. Good surgeons are actually pretty good at reading their own imaging as well. And especially good neurosurgeons that I've worked with and orthopedic surgeons. Then obviously CT is really, really good. CT and MRI, they have two different functions, right? CT is really good for bones, for finding your hardware issues, any sort of healing, like how the bone graft is healing, that sort of thing, finding fractures. CT is also very good for hemorrhage, right? And I don't know, earlier the talk, where you have very few doctors, being a neuroradiologist, I also think of bread and butter stuff like just stroke, post-op stroke from hypertension or something like that. For that as well, CT is very good. It just takes like 25 to 30 seconds. We have really fast CTs now. 60 slices, and in a couple of seconds you get like the whole scan done. Then obviously MRI. MRI is very good for soft tissue evaluation, infection, any cord stuff, cord injury, and that sort of thing. Nuclear medicine again is good for infection detection. We have different scans, we have Indian and what have you. There are many new imaging techniques like DTIs, and we do like whole loads of new stuff at Cleveland Clinic for tumor follow-up and all, and also for very targeted surgery, which can be very useful. So let's look at the big categories that we're going to be talking, the complications in the basket. So we'll start with mechanical issues, infections, neurological complications, vascular, and adjacent segment disease. So mechanical complications, these are mostly essentially hardware complications, right? Like loosening, fracture, that sort of thing. And sometimes then you have not getting the actual effect that you were going for example, pseudoarthrosis of non-union, or just malalignment, sagittal or coronal imbalance in the patient after surgery. And then we'll look at some imaging examples for such. So hardware failure, what are some of the reasons? Every patient is a little different, and one size fits all is not always true. So some of the reasons could be, the screws are too short or too small, or the insertion is short, or the fusion is long, or there is anterior column insufficiency. And these are some of the causes, and then we can look at the consequences from that. If the screw is not positioned, it will have poor hold. If it's too large, it could go through and through, cause vascular or dural injury. There could be tapping injury. There could be, poor ambulation and osteoporosis after that. I know some of the surgeons are also, you guys are doing vertebroplasty, which has become very common these days. So this is an example. You can see that the cement is leaking through and through into the fecal sac. And being a neuroradiologist, you know, I always joke that we only know half of our brain, and the other half, the better half, we still don't know what it does. So tiny needle, like a tiny point in the brain or in your spinal cord, which is so small, can literally control your other whole side of your body and so many functions. So just that much mass effect in the limited space in the cord is going to paralyze the patient for their life, and that's a big death sentence for someone. So you know, I understand, you know, some of these procedures are very complicated and you have to be very precise, but they have a significant outcome on the patient's life after that. And on the other hand, it could be the patient starts walking right away after their surgery, and they would thank you as if you're their God. So you have both sides, right? Let's look at this case of subsidence, and no fault of anyone when something like this happens. You know, this is just like an unfortunate outcome that can happen. You can see, you know, there is an interbody graft. It's just for whatever reason, you know, sometimes this can happen, that the bone sort of collapses along the direction of the loading force, and essentially you'll have to go back and try to fix this thing again. And this patient also seemed very osteoporotic. Here's again, you know, another example of this malpositioned screw. You can see it has gone through and through the thecal sac. That's where your spinal cord is sitting, and you know, it can cause a dural tear, which is not good. Again, here you see that the screw has come off from the back, and we see that the plate has lifted up, and this is a good example of implant loosening. And then here again, malpositioned screw. You can see that the cortex has gone through and through and sitting very close to the vessel adjacent to it. Infectious complications can happen. You know, just have to be careful, but I think imaging is really, really helpful in those situations, because symptoms may lag behind, and patient may come back after 2 days really septic and really sick. So you want to avoid that. Common things are common, you know, discitis, osteomyelitis. MRI is very, very good at detecting it early. You could have epidural abscesses, and both CT and MRI are good. MRI is good for the actual evaluation of the cord, epidural abscess, discitis, osteomyelitis, and CT is good for bone destruction. Here's an example, you know, at L5S1, you kind of see that bright signal on stir, and it's avidly enhancing on the post-contrast. So that's a typical discitis, osteomyelitis after fusion. Here you can see a schematic diagram, essentially, you know, the infection spread from the disc and adjacent bone to the adjacent epidural region, forming an epidural abscess. The most common cause actually is hematogenous. So if you have someone who's taking IV drugs or other risk factors, you know, this is something you have to be cognizant of, and perhaps, you know, opt for early imaging in those situations. It could also be direct inoculation or an adjacent infection that could have spread. Now this is a bad one. You don't want your patients to have the neurological complications, because these could be a little bit harder to fix. Other than epidural abscess, epidural hematoma, cord or nerve root injury or compression from any of the above. CSF leak, that's another one. And we do have interesting new MRI sequences that we do, especially for CSF leak. That we can find out specifically where the leak is based on these very high resolution, even 11 Tesla MRIs. And that could lead to a pseudomeningocele. And of course, arachnoiditis, where you know, there is eventual nerve root damage. So here you can see, you know, this is an image of CSF leak, pseudomeningocele. You can see the defect. This is the postoperative defect posteriorly, where posterior decompression has been done. This is a T1 weighted image, and this is T2. So T2 is very good for fluid. It's just different imaging sequences are done based on the physics. You know, you essentially change the magnet direction, and we get different images based on that. So here you can see the bone structures and outline little better. T2 you kind of do to look at anything containing fluid like CSF. And here's the defect, and you can see this collection sort of connects with the thecal sac. And this is a pseudomeningocele. This is an example of arachnoiditis, and you can see, this is called empty thecal sac syndrome, where all these nerve roots are all clumped up and they are fused posteriorly, and these patients will have long-standing, nerve symptoms, and kind of like hard to fix once they are already here. Not much you can do about it. Vascular complications, I mean, this is the most scariest complication, and you want to avoid it as much as possible. Things happen, difficult patient, difficult surgery, but again, imaging is your friend, radiologist is your friend. So do make friends in the radiology department, and get to early diagnosis. So vessel injuries, vertebral or segmental artery injuries can be very difficult to detect early on. The big vessels are a little bit easier. Post-operative hematomas, they can get infected also, so it's a good idea to get them in early. CTA or MRI, again, would be good at detecting them. Here's an example of vessel injury. You can see that screw that went through and through. That screw should have been here, but this screw has sort of gone outside the bone, and it's sitting right next to the aorta. You can see it here. Thankfully, there's not big hematoma or something. It's just about gone through and through. So sometimes these things could be difficult, and it's hard to keep traction, but this is a very deadly complication. Again, just a schematic showing the same thing. So you go and fix L5 to S1, and now you have to, patient continues to have symptoms because now they have altered biomechanics, and they get disease at a higher level. Now L4, L5 is acting up. So that's very common because we stand and walk straight, and that biomechanics has changed. Right, so adjacent level disease is common, and that's why we recommend follow-up, which you guys do. Any new symptoms, new disc degeneration, recurrent disc bulge, or any of the above from altered biomechanics, facet changes, and that would cause new areas of spinal stenosis. Spinal cord and nerve root injuries, that's where MRI is very, very helpful, and it demonstrates cord issues to great accuracy, cord contusions, cord injury or edema, or even infection or compressive myelopathy from epidural hematoma or abscess or what have you. Myelomalacia or serous formation comes a little later. Nerve root avulsion injury or scarring, again MRI or DTI are helpful in those situations. Here is an example of post-operative scar versus disc. It's a common problem. This is a post-contrast image, axial image, and this is a pre-contrast. Anyone can tell the difference between these two? So essentially this is the pre and this is the post. So I purposefully put the post in front because I think you see better, post contrast are usually easier to see because of the enhancement. And you can see that this is a site where discectomy was done, and now there's this whole area of enhancement. And the patient had their surgery and everything was done fine, and then comes back that I continue to have pain. And the disc is gone, but now there's all this scar tissue that's enhancing, and look what is done to the nerve root. The nerve root is entrapped in that scar tissue. So the way to find these scar tissue is do a post-operative MRI with contrast, and if it enhances early, it's a scar tissue rather than recurrent disc. And this is what this case is. So back pain and instability, small number of patients continue to have same or worse back pain after surgery, and there are like myriad of causes for that, or sometimes you just cannot find any cause. And when that happens, there's a basket term for that called failed back syndrome or post-laminectomy syndrome. And you keep looking and you can't find any reason why patient continues to have this back problem. Surgery looks pristine, imaging is clear, and you cannot find any reason for the patient to continue to have pain. So that's when you label it as failed back syndrome or post-laminectomy syndrome. So in summary, I would say timely imaging is very important, and choose modality based on surgical complications. So if you think it's like a screw fracture or malposition of hardware, I would say that get a CT rather than an MRI, because MRI will have a lot of susceptibility artifact, and you may miss hardware malfunction in that case. And CT is pretty quick, and you don't even need any informed consent or anything, like literally less than 1 minute. It would be 45 seconds and you'll have your scanner done. Patient is in and out. Post-operatively, they cannot lay flat for too long anyways. And then multidisciplinary approach, obviously, call the radiologist. I know like the best surgeons, I've learned so much from my neurosurgeons and vice versa, and orthopedic surgeons. So I think that for us also, it's actually, I love interacting with my surgeons, and gives me job satisfaction also, that I'm helping them find out exactly, answer their questions, what they may be looking for, and that way you feel part of the team. And that's it. Any questions? Thank you.
How early after surgery can MRI detect
So actually MRI is a little delayed, at least 2 weeks before you start seeing symptoms. But we don't usually do diffusion weighted MRI, which can detect things much faster. So like in stroke, right, the idea is whenever there's infection or edema, it leaks out fluid, the cell ruptures and it sort of leaks fluid in the interstitial space. That's what a diffusion weighted MRI can catch, and that happens pretty early. It can happen like less than 6 hours. That's how we have made huge advancements in stroke imaging with DWI. But with spine DWI, we don't usually do DWI because of the bone artifact. But if you wanted, you could do it earlier. I think what people tend to do is do blood culture or see the rising white count, and by the time they come, the MRI is usually positive.
Can I say, great talk, sorry I had to step out for a second, but with all the advanced imaging, we still see wrong level surgery. And I just want to say that to the younger people, the residents here, when you get any of these advanced films, intraoperative CT, whatever it is, your tendency is you just did something, you want to look at what you did. I tell people, before you focus on what you did, number one, make sure it's the right patient, who's right here in front of you. Number two, make sure you're at the right level. Because we have cases where we've done intraoperative CTs and everything looks great, but it was at the wrong level and nobody noticed that until the patient came back with recurrent symptoms. And the other thing I want to say is chronic equine syndrome is a clinical diagnosis. It's not a radiographic diagnosis. It's supported by radiographic findings. And then finally, the worst thing that's happened to me in 20 years is the fact that the patients can access their radiographic studies frequently before I even get to look it up. And they have no idea what the terminology is, but then they Google arachnoiditis or they Google something, and then I have to spend a significant amount of time.
Yeah, unfortunately, I think now with ChatGPT, it's just going to get even worse. I think that's been an issue forever. And with Epic, I think they're also talking about having a patient portal. So patient portal. So
They have it.
Yeah, they have it. I just want to see, say one more thing, because one of my research paper actually is talking about wrong levels, especially in spine. Sometimes you have transitional vertebrae, so the numbering is completely off, even between radiologists, and that's something we are working on. I don't know what the surgeons use as L5, S1, but at our institution, we have kind of come to a consensus that L4, L5 would be at the level of the iliac crest. And when there is transitional vertebra, if you have a lumbarized S1 or sacralized L5, all the counting is off, and that has been a big cause of surgery at wrong level.
7%, in my experience, 7% of patients will have a transitional segment, whether it's, 4 lumbar or 6 lumbar. And so the only thing I've found to be effective is when the radiologist says, for the purposes of this dictation, series 7, slice number 8 is considered to be the L5S1 level. Because I can't see the iliac crests as a surgeon, but I can go to what the radiologist has identified as L5S1 and say, okay, that's what you're calling L5S1. Now I know where your mind is at. I'll still call whatever else I want to call, but at least I'll know that's what you're calling L5S1.
Yeah, I think it's institutional, which is also not good, because if the patient goes to some other hospital, they may not do it that way. But I guess the surgeons and radiologists at our institution just agreed to use iliac crest as a landmark, and just throughout. So radiologists decrease the inter-user variability also among radiologists and for surgeons also. So that's what we are using. I'm sure there'll be like some new AI models coming out for the same thing, and I think that should make it easier.
Thank you very much for your time talk. So I have actually 2 questions. So the first one, what's your experience with or how much common like your institute using the discogram? The second question, what do you think the best image for SI joint disease? Because both of them, I think they cause a significant percentage of patients with persistent back pain, or what we call even post-laminectomy syndrome, and yet they are under did not get the full attention or
Yeah, I would say different school of thought for different issues, right? So I trained at hospital for special surgery, and we had 11 Tesla MRI there. So that's very high resolution, and you can see, you see the nerve roots really, really well. Like we are imaging, hand ligaments and all, and you look at that with great precision. So the idea is to be getting maximum information with minimal intervention. So with discogram, I think some surgeons love it, some surgeons not so much. Focus on the solution. What are you trying to find exactly? In some situations, it's very useful. So we used to do, but it's very surgeon specific. Some surgeons really like it, and we would do it for them. For sacroiliac joints, imaging is all about protocols. I cannot image sacroiliac joint the same way I do lumbar spine because it's angulated. So the MRI has to be, the protocol has to be sagittal oblique for you to see the imaging. So you would order a specific exam for sacroiliac joints. And there should be in the, at your institution, should have a special pelvic, it would be pelvis exam, not lumbosacral, and it would be dedicated for sacroiliac joints with angulated oblique sagittal views through sacroiliac joints, and the images come out beautiful. You can see both joints at the same time. Whatever you're looking for, you know, sacroiliitis or ankylosing spondylitis.
Or degenerative, usually.
Yeah. Yeah, order pelvis exam, but put a note for radiologist for sacroiliac joint imaging, and we've been doing beautiful imaging for sacroiliac joints.
Just in a matter of time, we're going to have to limit the rest of the speakers to the 15 minutes. So please, if we can, otherwise we won't finish in time. Thank you so much. We would all love it if you came back next year so we could ask you some more unanswerable questions. Thank you, and here's a plaque you got for making Dr. Meadville. Going to talk to us about something many of us in the room know absolutely nothing about. Hope you'll take that into consideration when you give the talk. Treatment of the intertrochanteric hip fractures.
I'd like to thank the group for allowing us to present our information. I am a reformed spine surgeon. Most of you will be bored by this talk, so I advise you to use it just for information. When I did my spine fellowship, which was 40 years ago at Northwestern, we were doing mostly traumatic spine. We had no CT scan. We used tomograms, and we used clinical exam, and we used X-ray. So now that we have MRI scans and diffusion scans, and nuclear medicine was called unclear medicine when I was a resident, because we could never figure out what they were saying, and they never knew what we were asking about. So now I do things that are a little bit more straightforward, and I ask your indulgence. I did this with my daughter, who is an intensive care unit nurse, and was working in my office and tried to figure out why people were having failures. We have failures in orthopedics and trauma fixation also. I have no disclosures to make. Intertrochanteric fractures, as all of you know from your medical school training, are between the two trochanters, the greater trochanter and the lesser trochanter. They are outside of the hip joint, so they're an extra capsular fracture. All of us in this room, even the younger people here, are going to be at risk for getting this fracture if we live long enough. Osteoporosis is affecting even the men here. So in the old days, men thought they didn't get hip fractures, and that was because they died of heart attacks first. Now women have caught up with heart attacks, and men have caught up with hip fractures. So we're all at risk for things like this happening to us, especially those of us over 65. Our bone starts to weaken even after the 20s, so osteoporotic fractures and treatment of osteoporosis, which even the neurological surgeons in the group may want to consider with the spinal interventions that they're making. Usually these fractures are the result of falls, which I've gotten to the point in my life listening to patients that I expect to go to Walmart and see people lying on the floor because they've fallen, because everybody seems to fall. These occur in about 50% of hip fractures, and you can see there's over 150,000 of these fractures a year. The average age for this fracture is over 80, so people in their younger ages of, quote, middle age, if you maintain your fitness and maintain your agility, will have less likelihood of this happening. This shows some of the anatomy. This is an extracapsular fracture, so Most of the times we don't have to replace the fractured portion, but rather can fixate it with an open reduction internal fixation, and with proper vascular supply, this is likely to heal. As with many things, there are classifications. The group that started in Switzerland, the AO group, came up with a classification system. If I talk to residents and they tell me it's an A13C fracture in the middle of the night, I have no idea what they're talking about. So these classifications are good for papers, but they're not as applicable in clinical practice. And I think the real concern is here. Is it stable or is it unstable? As an orthopedic surgeon, I'm not quite as smart as the brain surgeons here, so we have to have really simple things. These two are pretty stable. These are unstable. And even in the middle of the night, the resident can tell you those things. It's comminuted, intra-articular, it's probably unstable. What we have found out that if these extensions go into the subtrochanteric region, down in here, then that is going to be unstable. If the fracture goes instead of intertrochanteric in this fashion, if it's a reverse obliquity, something like this, then it is an unstable fracture, even though ideally you would think this is a very stable configuration. Our choices for treatment for this open reduction internal fixation are dynamic compression screws, which we use traditionally, cephalomedullary nails, which we place through the greater trochanteric region. The 95-degree plate is, I don't think there's, even the orthopedic surgeons in this room probably have done 2 or 3 of these in our careers, because we don't use the plate very much. We sometimes use a dynamic compression screw, which does have a 95-degree angle, but most of our trainees have never used this technique. I've had PAs who have done more of these cases with me than I've had residents. But the sliding hip screw and the cephalomedullary nails allow for a fixed angle collapse, so the fracture is allowed to compress, which gives it better healing potential. The American Academy of Orthopedic Surgeons recommends that you use either the sliding hip screw, this is supposed to be, or the intramedullary device for stable fractures. The other fractures you can treat with intramedullary fixation, which gives you a better biomechanical construct and has less likelihood of the screws coming out. This shows you one of these devices. This is a short intramedullary nail. It can be placed in through an incision, probably about 2 to 3 centimeters here, 2 to 3 centimeters here. Patients like that because if you put a big dressing on, when you take the dressing off, they think you're a wizard because they only have small incisions. Doesn't make you any smarter, but it makes them think you are. The older designs, the angle here was of the rod was a higher angle, and it tended to make the screw cut out at the top. But the newer designs have less of an angle. These started out as a gamma nail, which was developed in Europe. We tried to adopt that in this country, but as that cut out, it was redesigned, and now the less angulation here allows you to get a better construct with that screw. What I'm a proponent of is the use of longer nails, because I think if you stop here, and I'll show you a couple of x-rays, the entire rest of the shaft has potential for fracture, and you've created a stress riser at the bottom of the nail. So frequently we'll get a problem with fractures after internal fixation, and these create a much more difficult problem. The disadvantages of these long nails are there's a femoral bow, and we have to try to match the bow of the nail to the bow of the femur. With the distal locking, which you see down here, that has to be done freehand. So it's a challenge for even the most adept, and that can lead to increased blood loss. There's also a question of increased cost as there's more metal being placed. It's a larger device, and it's a more expensive device. But I think if you looked at the cost of reoperation, it may, in fact, compensate for that. With the screw placement, which is the lag screw, you want to place that so that the tip apex distance is less than 25 millimeters. So if we go back, the tip of the screw here should be within 25 millimeters of the joint. And especially with residents, you worry about that screw being placed into the joint with can create a problem in terms of degenerative changes in the hip joint. If that screw comes up against the articular cartilage, then you end up having hip arthritis and having to change that screw later. So the tip apex distance is critical because that gives you a stronger construct. There is a type of implant called the helical blade. Many times when you place that screw, you have to drill a hole, and then you place a larger bore screw into the hole. If you use this helical blade, the blade is actually a self-cutting device, and you can then, in theory, impact bone around that, rather than having to remove any of the bone, especially since it's going to be osteoporotic. These helical blades also are fenestrated so that you have the possibility of putting bone cement in through the helical blade. So those who are doing spine surgery, we talked about screw cutout and displacement. I think it would be an interesting concept if you could find a way to fenestrate the pedicle screws, and if you were able to pressurize cement and put that into the vertebral body. I think that would be an interesting concept to see. Does that decrease screw cutout? Something. And so yeah, and in the old days, what we did was we would drill through the pedicle, would place bone cement, and then place the screw. Of course, there's going to be extruding the bone cement, but now if you have a fenestrated screw, you can do that. I think that's better. The other thing that we sometimes do, and I've done in the past, is put patients on what you would use for osteoporotic bone treatment, and see if you can increase the bone strength for 2 to 4 months at least prior to doing a spinal fixation, and that may give you a stronger construct in terms of the bone in the spinal vertebral body. So the cement augmentation will give you interdigitation in the bone, gives you a stronger cutout, a stronger bone construct, reduces your cutout, and we have found it is superior to just the screw itself. Not all of the products have the fenestration, and you're putting the cement in at a place distal from the fracture site, so it's not going to extrude out of the fracture site. But as we said, if you penetrate the head, even with the guide pin, by placing that bone cement, it has a risk of extruding into the joint. So you have to make sure that the head is not penetrated by your guide pin. So these are the advantages of the distal lock. It creates a more rigid construct, but you have increased time because of the freehand insertion. But I think once you have gained a little bit of skill in this, it gives you a better option. Here, a subtrochanteric fracture that was treated with a long nail, but what had happened is this is that reversal obliquity or subtrochanteric area. If you place a short nail here, it's not going to work because the nail is not long enough, and here a distal lock. So this construct, in fact, did heal. Here, an appropriately placed short nail. I think you could use short nails in trauma, especially in younger patients, although most of the patients sustaining this injury are over 65. But in a younger patient, this is a quick and easy way to get things done. And in a younger patient, as you've seen, we fill the canal here, less likelihood of the stress riser here creating a fracture. But that's what you see in this situation. Here is the short nail appropriately placed, but a distal fracture. So now what we ended up having to do, because this is parodic bone, place a nail from the knee up to intersect here, but here we have still a stress riser. So because of the parodic bone, because of the poor control of rotational stability, there's a plate placed here with screws going up to here, a screw here, so this construct eventually healed, and it took about 4 to 5 months. Here, an appropriately placed short nail, but the stress riser that created that problem. So this nail had to be removed. The problem now is that this screw has been placed into parodic bone. So now you've got to either match exactly where that screw was, put more cement in there, and then you've got to take this out and put a longer rod. You see, here's the longer rod with the locking screws distally that takes care of the entire construct. So in conclusion, I think longer rods rather than short rods are useful, especially in geriatric patients. I think it reduces the risk for post-rotting fracture. I would use the largest diameter rod you can use. There's a question that the reps ask all the time, do you want to ream this? I think reaming out the intramedullary canal and osteoporotic bone is ill-advised. The distal locking screw will be helpful, especially if you have parotid bone. There are two major degree angles. The 30-degree angle is better than the 125. It has less cutout. You can use cement augmentation. One of the things that you can use to cut time is if you measure the rod length before your surgery by measuring from the greater trochanter to the top of the patella, that will give you about the size of the rod length. That would cut down on some of your time. And then by checking the intramedullary canal, you can fill that canal. And as again, the preoperative measurement of that rod length will decrease your time. Thank you. Sorry.
Dr. Belcher. Great, come on up. Start step forward. We'll take one question. Which is more difficult, spine surgery or this?
I think when I started spine surgery, that was at a time when we could not say you were using pedicle screws because the lawyers got involved, so we had to call them bone screws. And so now everybody calls them pedicle screws. I think the spine surgery is more difficult, but I've not done so much because before we started doing all of the spine surgery, we never had the specialty of pain management.
Thank you so much for joining us. Thank you. Dr. Belcher's going to speak to us about wheelchair to walking again.
Yes.
For cervical spondylotic myelopathy.
Thank you. Dr. Blusher from Michigan. I've been in spine. I used to be an ortho doing a lot of trauma and joint replacement. But in the last 7 years, I switched to mainly spine. Been in practice for 3.5 years now. So this is one of the my cases that when I look back, I feel like some satisfaction how my patient's been doing. So that's what I'm trying to share today. So no disclosures. This is 61. Actually, this surgery was done in 2023. 61-year-old morbid obese gentleman who was self-employed, having a truck, working for interstate. You know, those long distance driving. He was again taking care of his business. One day he started having some pain in his right leg. He thought maybe just some muscle spasm of being having a long drive. He didn't pay attention. That happened around the spring of the 2023. Then he just checked it with his family doctor and said maybe just having some hip problem. Being checked by a specialist, say no hip pathology. Then the things start getting more, having more weakness in his right leg, and having also some upper extremities symptoms where concern were maybe carpal tunnel being evaluated, some EMGs, and all of that shows it's all related to cervical spine. That's where the gear was shifted to the cervical spine instead of the lumbar. And that's where being evaluated in this late summer 2023, being diagnosed with the cervical myelopathy, was seen by in our practice by our by our neurologist and our pain specialist, and then they refer him to my colleague. They were concerned about his progression of the motor deficit. Patient, as I say, was a truck driver to the point now he started using his mother as a wheelchair to ambulate besides he's walker dependent. Because of his again, his body habits might lead, he didn't feel comfortable to take him for surgery. Plus, he was work-on. It took like forever to get his approval for surgical decompression. That's the some of his X-rays, but that's his MRI preoperatively. As you can all see, that's the amount of the stenosis, central stenosis that he has, mainly from the C4 to C7 there. And again, finally, I think my office took over. We were able to go through the bureaucracy of those work count patients. Then at that time, again, he was mainly like walker dependent. He has all the cervical myelopathy, upper and lower extremity, even the left lower extremity starts being affected by the, that was, let's see, yeah, this is the CT, just to appreciate how much is the calcified disc there, the C4-5, how big is that ossified, and then even how that goes all the way lateral. It wasn't only just central, and then was the all the time for me again as a new start. What approach should I take? What should I do? How much should I do for this patient? ACDF or corpectomy or just posterior cervical of 360. So I decided to go for 2 stages. Stage 1, which is 2-level corpectomy, and then back it up with the C3 to T2. So that's some of the intra-op images of the corpectomy, and again, interestingly, when I did the wide corpectomy, I'm sure now you'll see 2 big cages sitting next to each other. Corpectomy was like, he's a huge guy, again, like I measured was 27 centimeter. So the widest corpectomy that I have at that time, either expandable or statics, was only 20. That's for me, that's where I stick 2 12 to each other. That's where it gave me at least 24. And then, again, that's how they look like on the X-ray. Stage 2, traditional posterior cervical. I needed to extend it all the way down to T2 because of, again, he's a big guy, and I don't want to take risk on that construct. This is post-op MRI, which is again was done around just for the purpose of to see. Let's go back to the his pre-op MRI, trying to see if you can appreciate the core changes there, which is, as all we know under radiology, they can testimony for that. That changes permanent is not going to be seen, but this amount of the decompression compared to the pre-op, how it looks like. Clinically, patient did great. I think I have even video for him. That was 7 months post-op, where he's carrying his walker in his hand. And I just been in touch with him now after almost 2 years. He's back to his truck. So again, for me, again was a decision: just go safely posterior, or just go after that anterior ossified. That was for me some challenge I have to make, decision-wise. But again, it all comes down to the clinical outcome, and that's where, again, one of the cases that I feel satisfaction after you do it. That's it.
Dr. Al Rawi, come on up and get yourself step forward. So that was fantastic, and Thank you. Questions at all? We have a thank you. Can I suggest, we do BMIs 35 as our cutoff now, interestingly. So I don't know what the group really is, but we put them on the medicine for 7 months.
You watch the because of the.
Unless it's,
My long term like this.
unless it's a different, but was it progressing?
Oh, yeah, progressing. From March till August, it was progressing in March. August, it was a wheelchair.
All right. Dr. Alvar, can you give us 2 talks? Thank you for joining us in the UK. Try to keep this Perfect. And first talk is going to be on evaluating intraoperative challenges in adult spinal deformities, and then decision-making and stability with regards to thoracolumbar injuries.
Good morning. My name is Asfin Rawi. I'm a consultant spinal surgeon from UK, and I appreciate that you are accepting me for these talks. And the first one is about the adult deformities we get in this address. And I know when we start to talk about the adult deformities, probably it takes more than 15 minutes, definitely, to try to explain even a single idea in that a very wide subject. Anyway, I will try to put probably a couple of ideas that fits in the time, and please stop me if I try to take longer. I work in the James Cook University Hospital, and we have 1,070 beds. Actually, we have a very big spinal unit. James Cook, probably the second largest hospital in Europe. We have 8 spinal surgeons. The structure from orthopaedic background and from neurosurgery background, and that's a kind of structure that we have. We do spine only, and in the northeast of England, we have 2 specialized spinal units in the whole of the northeast England, and that kind of the specialized spinal unit, that's the structure of the spinal practice in the UK.
How many spinal surgeries a year?
Per year?
Yeah, per year.
From my NHS practice, the last year it was 156 cases.
And in total?
In total. 8, probably that will come to something like 1,500 cases. But 156 patients, actually, not surgery, because, for example, if I do one of these cases that we will see here, I take them as one case. So it is beyond curvature, evaluating intraoperative challenge in adult spine deformities. And I have nothing to declare. And now, for adult deformities, we know that they present probably one of the most challenging cases when we deal with the more complex cases in spinal practice. And that kind of the difficulties and challenges it comes to in terms of decision making, which case that we will pick for the surgery, which case we'll go for conservative, non-operative. There is nothing like conservative, it's non-operative treatment. So the challenge will start from the day that we accept the patient in the clinic. And usually the decision making in these cases, it takes not just a single consultation. Usually those cases will take repeated consultations. Probably the first decision will be made at least after 6 months, after 3 or 4 visits. When we discuss the adult deformities, the first thing that will jump to the mind again, what kind of pathologies do we have a certain definition for this? Do we have a certain recognition of those cases, what we are dealing with? I think the adult deformities, we started to talk about that probably something like 20 years ago, and the mentality when we put that kind of the pathology comes from deformities as a comparative to pediatric deformities. So in our when we try first to recognize those subcategory of cases of spinal practice, the primitive meaning is that malalignment of the spine in patients who are not pediatrics. More or less the patients who are over 20, they are now adults and they have malalignment of the spine, so we try to gather those cases to call them adult deformities. But actually the term is a very stretchable term, it's a very flexible term, and now on practical basis, when we say adult deformities, we mean every single case that is more complex as a degenerative case, and that might need to deal with malalignment that involve more than 2 vertebral levels. So that will include any case of malalignment of the spine, that will include any case of repeated spinal surgeries, failed implants, a very wide group that include multiple pathologies, not just malalignment of the spine. And the other thing we used to differentiate in between degenerative deformities and adult deformities. That's a very helpful recognition. And as an arbitrary figure, the age of 55, until the age of 55, when we see the case of deformity, we try to call it adult deformity. And after the age of 60, regardless why there's a deformity, we call it degenerative deformity. And that kind of recognition, arbitrary figures, it helps for the prognostic value, because when the deformity and when we deal with those deformities, especially when it comes to the surgical solution, after the age of 60, the prognosis tends to be much better than when we treat those cases who are below the age of 55 or 60. These are just arbitrary numbers. I'm not sure why, but that is. And now, again, we said that the recognition of these ages. And with regard to the definition, probably if we try to coin that adult deformity for any case of malalignment, probably we have, as Schwab has represented in this paper, we have malalignment of the spine, some degree of malalignment, 68% of adult scoliotic deformity in patients who are aged over 60. So if we pick one person case from the street without any symptoms and we take standing x-rays, we will find 68% of them have a sort of malalignment. Again, lots of figures about lots of lines, lots of figures. I don't find them very helpful, especially when it comes to decision making. The only thing that I find as very helpful is the lumbar lordosis, which is the main factor. It's the starting factor, because with a normal lumbar lordosis, everything, all the other parameters looks to be okay. The other thing is the mismatch in between the lumbar lordosis and the pelvic incidence. But we know that pelvic incidence is a stable factor. We can't do anything for that. It's stable. What's changed is the lumbar lordosis. So if the mismatch, which is the main factor there, it is because of the hypolordosis or kyphosis of the lumbar spine, because of degenerative process. So the main factor, the initiating factor, is the lumbar lordosis. All of these figures, all of these lines, I think they are helpful when we do the research to compare different treatment methods, different surgical techniques. That helps as outcome measures when we try to do the research. But on terms of intraoperative, I don't find them any helpful. I just put some of these classifications to show that the mentality when we try to recognize these pathologies as a specified entity, people try to put a classification system. Some of these actually they come from orthopedic guys. We like classifications, but actually they are not helpful, because, as I said again, the term adult deformities involve lots of things, and try to focus our mind that this is just malalignment of the spine. It doesn't help at all. At the end of the day, what we need for those cases is to try to assign which patients will need the surgical treatment and which patients will go to less invasive techniques. Having the malalignments more or less does not really help to decide which patients will go to our theater and which patients are not good candidates for the theater. Again, other classification. What I liked in this kind of type of classification is that he tried to group the cases based on the flexibility of the curve, which is the main focus of this talk. Is that what I found, as I will come later, that flexibility, or in other words, actually rigidity of the curve, which makes the case more challenging to address intraoperatively. So I like that kind of the classification. Again, same story. Now yes, I find this is very interesting in spine. Are we in our practice, in our profession, in our business as a spinal surgeons, are we closer to be a science, to the point of science, or are we closer to be an art? There is science, definitely, as part of what we are doing. We are scientists, we are evidence-based people, we base every single decision on what we are doing to be science. But we need to admit that on part of what we are doing is an art. And actually, I believe in spinal profession, we are closer to the art rather than to science. Yesterday, I was attending the meeting of general surgeons, and all the talk was about the cost and the complications. But in spine, we have the complication and we have the results. Because in spine, again, as long as we get inside, yes, safety is a major issue, but there are a wide difference in the techniques that we are using how to achieve the results. It is very easy to coin when I fail to address the pathology to call it, oh, failed back syndrome. So the one that I have seen with the least rate of complications are those people who doesn't do anything. So who doesn't go beyond the red lines to address the pathology. So we need again to admit ourselves as we are closer to the art. And I don't mean by being an art the hand skills, the surgical skills. Actually, I mean that kind of the judgment, that kind of the vision, that kind of insight. When we meet the patient to try to coach patients, we'll get the more proper technique, more proper decision, and that kind of things. I think this is a very specific part of art that we need to focus that when we try to refine our training programs, when we try again what we will do as the next step. Rather than just to take ourselves, okay, we are scientists, not exactly in our profession. So if we believe that, okay, we are science, I think that will be the result. Okay, now if I send someone, okay, no, go and do that kind of give me that piece of paper. Well, the paper will come to me whether that way or that way. But if we are arts, if we tell them go and do that kind of the job, that will be the result. One will produce that kind of the external piece of art and that kind of the piece. I hope I can make my point clear. Now, I think we have probably something like 5-10 minutes. These are the cases that we see for when we talk again about that subject of adult pathologies. This patient again, 76 years old male, multiple comorbidities, multiple surgeries again. With the, if I go probably to that picture again, what they did over here, I think they have taken as the literal meaning of the fusion. So they did one decompression, it didn't help. Second decompression, third decompression, it didn't help. Oh, now I need to fuse this one. And when they fuse, they take the literal meaning of the spine. I think they put all the bone grafts of the wall there to try to say, oh, this is a fusion. And here we can see in the X-ray what kind of a fusion mass is there. This is again another, probably this represents malalignment. It's severe malalignment, but actually the point that I'm trying to make here is that the severity of the deformity is not the only factor, is not the main factor to make the case more difficult to be addressed. It is actually the rigidity. So for example, this case, despite having a massive malalignment, this is not the most difficult case. It was a flexible curve, and addressing this curve was not as much as difficult as for example, the previous case. Again, that's the MRI scan of the second case. And this again, another 84 years old, severe symptoms, osteoporosis, arrhythmia, cardiac pacemaker, which again makes the things more difficult. So that is a simple group that I'm talking about. I'm not talking about some case of malalignment, classical sciatica that everyone will go put A-lift, X-lift, T-lift, and address. I'm talking about that subcategory of patients where the next level of the complexity comes, and how to have again the deep insight, how to address them, and what kind of intraoperative challenges I need to expect to try to do that. Again, another example of someone, 82, 8 months, cannot walk, cannot sleep, cannot serve, and there was a very interesting discussion with this patient. We did I don't put the other image actually, with the aortography, contrast aortography, the anterior part of the disc was adherent to the aorta. So I told him, again, well, it's very difficult to do the surgery. He's 82, and that adherent piece, we can't do multiple surgeries, it's not fit enough. And if we do it from the back, again, I told the patient that's probably 40-50% chance that once we will try to reduce the kyphosis, and then this might tear the aorta, and then he asked me what will happen. No, you'll die. then I don't mind, let's go for it. I don't want you to die with my table. He said, well, okay, we have to do it. I will contact my funeral if you would like. But anyway, we have done this case. The point for me, again, when I put these cases, we need to be reasonable what we are trying to achieve. We need to have a proper discussion. We need to have a proper plan. We need to see what we expect intraoperatively. So again, different stories, 78 history. What I mean, again, in putting those cases, the challenge that we face is that the rigidity of the care that we have is one of the major factors that makes the case more difficult. The fragility of the patient, most of those patients who are over 70, they come with lots of comorbidities. And the third thing is that the fragility of the bone, the osteoporosis, makes correction even more difficult. So these are the main factors rather than it is the severity of the curve. I don't underestimate the severity of the curve, of course not, but what I mean, especially when we deal with those next level of complexity of those cases, probably the severity is one of the factors. Other factors are equal or even more important. So that, again, this one has probably something like 7 surgeries before, and it reached a stage that there's complete dissociation in between. That's kind of a fused, completely fused L4 one, and the upper level, adjacent level disease, but ended with a massive, with aggressive dissociation. And the patient, again, obviously, she has hypertension, renal failure, osteoporosis, and on a wheelchair with the massive pain, and she's the IP. This is the same patient. This is what I mean again. So basically, if I try to take again correction of the curve, we can remove the implants, we can extend the fusion and the instrumentation high up. But what happens here, this is a proper planning, that this is the curve that comes from the sacrum and then 30 degrees, probably something like 30 degrees with complete fusion into the sacrum, and then the spine try to correct itself. If I try, for example, so if I try just to make it simple and re-correct this to fix it there and there, then what will end is that we have that kind of the curve here, which invitation of another failure. So even though I need to osteotomize this one in order to try to minimize the chance of further revision in the future. If I don't osteotomize this one and try to correct that, then just another failure will happen. Yes, then we'll go again, another case, rigidity, something like that. I will again go for this. The difference for this case, I put it, this is a post-traumatic, which is again, even though this case looks to be a very complex, it is not as complex as the others. Because this case, 47, and he does not have that kind of comorbidities. I can put him anterior, posterior, 6 hours, 7 hours, whatever it is. Not like the other cases. If I try to exceed the 5 hours, which for me it is the red line, 5 hours, 6 hours, then we will enter the complexity. This patient, there is no problem of putting him 2 surgeries, 3 surgeries, no problem. And then, okay, that's the kind of the correction here. I will go for these slides. I think I showed my idea, what I'm trying to say. And selection is the key, always. And rigidity of the deformity is the key. Properly chosen instrumentation segments and adequate spine osteotomies, flexibility correction could be obtained with that. Posterior spine osteotomies, grading. The key point, severity of the deformity is not the only difficult factor. Flexibility and rigidity of the curve are probably more, put the case under the more complex category. Patient fragility, associated comorbidities, and bone fragility are also the main factors here. Now, these are some of the results of the case that I have shown here. For example, this was one, this was the other one, and that was again with the complete dissociation, with the osteotomy. That was the gentleman here. And that was the other case. And as a conclusion, patient selection is the key. 3 factors to determine the intraoperative technical challenges and subsequently may define the ultimate deformity correction result. It is the curve rigidity, as I'm trying to focus. Curve rigidity, patient comorbidities, and the ability to withstand the stress of lengthy surgery, bone quality, and osteoporosis. And thank you.
It's a matter of time. I'm going to hold questions. Dr. We'll have you move on to the stability and decision making in practice
Yes.
for our injuries. Maybe time for one question. I agree. It's very much in our
Yes. I will try my best. So now the second talk is about the stability and decision making in thoracolumbar injuries, insights from the two-column theory. I presented myself and I have again nothing to declare. In spinal surgery, once we receive a case, I'm on call. I got a call from my fellow. There's a case of spinal fracture, and then the first thing to jump to my mind, to my fellow mind, is that the instability, the classification and decision making, and surgery or no surgery. The difference in determination of the injury, stable, unstable in the spine is entirely different from the concept of the stability in other orthopedic trauma. For example, when we have the RICE presentation about intertrochanter fractures, the classification is stable or unstable. It doesn't matter actually, because unstable or stable intertrochanter, we have to fix it anyway. But in spine, it's completely different. The classification in spine is extremely helpful to decide which side of treatment we will take. If I decide this injury is stable, then that's it. I don't need to worry at all. I don't need to give the patient any form of treatment. Legally, I'm protected. Everything is helpful for me. Once I have the classification system, once I have decided that this injury is stable, there is no need for more actions here. And on the other side, if it is unstable, then I need to find a form of treatment. A very basic definition of stability, again, that's we take from White Punjabi. Stability of the spine is the ability of the spine and the physiological loads to maintain alignment, so there is no deformity in the future, there is no neurological deficit, and there is no chronic pain. On the other side, traumatic instability, the definition is potentially to displace significantly formation of deformity and the physiological loads to lead to deformity, neurological deficit, or pain. And that's the kind of, for example, of the fracture. So, for example, we had this kind of the injury on the right hand side, for example. It looks to be a bit benign, but with a closer look, probably I might see something like widening of the interspinal space. Here, there is that kind of the transverse process fractures here. Again, that kind of the fracture, again, looks to be destruction, injury inside the bone itself. Cervical spine, again, might be a doubtful, something like malalignment here, something like epiphysis there. Is that kind of the injury stable or unstable? So again, some cases when we see the spinal injury, some cases will be an obvious unstable injuries, other cases are obvious stable injuries, others in the gray area. The problem is always, even when I think this case looks to be entirely stable and benign, that's what we call probably occult instability. I always need to put at the back of my mind, these cases, they might still present a case of occult instability, and we need, again, always to have a very high level of suspicion. So, for example, this case, that one is obviously unstable from the first instance, there is no doubt. And for example, this case, which looks to be benign, just probably looking there, there looks to be something. And then, again, that's the image. And again, this one. There will be other images that will show this case is very clear, image of instability. So, about the, again, mechanical instability, biomechanical gravity, we have the forces, compression, tension, and torsion, which is with the grading system, which one is more destabilizing. Torsion is the most aggressive destabilizing, and then tension, and then the compression. That is a very, again, interesting, probably summarize all the idea of instability. From the 1970s to the 80s, again, the spinal orthopedic surgeons, they tried at that time again to formalize a system to decide which case or which theory we have, which concept we have to say is this injury stable or unstable. And we came with the Dennis, the three-column theory. It was a very basic theory. Still, some people are using it actually. That's okay. The spine is formed out of three columns that support the spine. any two columns, regardless if it is the anterior, the middle, or the back, any two columns disrupted, if we see in any injury, anterior or posterior, whatever it is, two columns disrupted, the injury is unstable. It's very primitive theory, it's very clear theory, and it has been used for a very long time, until the time when in 1994, Magyar and his team came to define another concept, entirely different concept, that the spine is formed of two columns, the anterior column, the compression side of the spine, which has nothing to do with the stability, and the stability is relying on the tension side of the spine, the posterior, the neural arch with associated ligament, and the strongest ligament among that is the supraspinal ligament. However, Dennis was talking about the spinal stability, while the AOT, Magyar and the others, they were talking about the thoracolumbar injuries. They excluded the cervical spine. And we actually, when we give the lectures, there is no talk about why we spare the cervical spine, why we exclude the cervical spine. And again, it is an inclusive question, but the answer again, well, the cervical spine is different in terms of load, in terms of stress, in terms of anatomic structures. The ligament nuclei, which is the comparable structure to the strongest ligament in the thoracolumbar spine, the ligament nuclei is not as strong as the supraspinal ligament. Oh, that's what we believe, at least. However, the point that I'm trying to put in this lecture is that the thoracolumbar injuries that was assigned, actually it works more for the thoracolumbar junction, where probably the 80% of the spinal injuries is there. However, the differences when we come to the thoracolumbar injuries, the difference in the upper dorsal spine in terms of structure, in terms of formation, the difference in between the upper dorsal spine and the thoracolumbar spine is equally, even could be more important than the difference in between the cervical spine and the thoracolumbar junction. That concept is also correct when it comes to the difference in between the lower lumbar from the thoracolumbar when we compare the difference to cervical and thoracolumbar. In other words, what I mean over here, and the concept that I'm trying to put, is that the two-column concept, it works properly, it works very clearly, obviously, correctly for the thoracolumbar junction injuries. It is not 100% applicable when we move away from thoracolumbar injuries towards the upper dorsal, and when we move away from thoracolumbar to the lower lumbar. The structures are different, the anatomic structures are different, and the lower lumbar and the upper dorsal. We have also the rib cage and the sternum as a supporting device, which makes the whole system entirely different. And that is the main point of this, again, of lecture. So again, this is, as we see, that there is a fracture of the L4. When I try to classify these injuries, I don't rely on, I'm an AO person, I entirely base my decisions on the AO, but that's for thoracolumbar injuries. When it comes to lower lumbar, like in this case, for example, I make my decisions in a bit different. So for example, for the AO, this is a stable injury. The concept that I take when I analyze those cases, I take them as one column injury. So if the patient is not on neurologically, and if the patient maintains the integrity of the anterior column compression or the posterior column, okay, for me that is enough. This is a stable injury. So in lower lumbar, I take it as one column theory. The structure of the spine in the lower lumbar is quite strong, that if the integrity of the posterior part of the spine is maintained, that is enough to maintain stability. Or if the posterior is disrupted and the anterior is maintained, again, this is enough to maintain the stability. Again, there is this patient who I'll go quickly through these cases. This is Charleston fracture, that is the classification of the AO. Again, the two concepts theory, the tension side, the compression side of the spine. And I put in the presentation, it takes longer than 15 minutes if we want to go deeper into all of these kinds of the injuries, classifications, how the X-ray is useful to classify these injuries, which one is A1, A2, A3. I don't think that's very helpful because A is stable, B is unstable, 3 is very unstable with rotation. So yes, that's the kind of the injuries that we have to classify these. I'll just go quickly through them. And again, I'm not here to discuss what kind of treatment we are doing for these cases, how the difference will be there. The idea, as we know, that stable injuries do not need stabilization. The indication of surgery for stable injuries will be only if there is a neurology deficit. However, once we do the compression, once we do whether it's carpacting from the front, whether it is posterior from the back, then we have to stabilize because basically the injury has caused destruction of the tissues, and when we go for further destruction, iatrogenic destruction by the surgery, we have to stabilize. So lots of images, lots of, again, how to differentiate whether there is rotation or no rotation. Once there is rotation, there is no place for conservative. The only place for non-operative treatment for unstable injury is in case of chance fracture, bony chance fracture, because if we maintain the alignment of the spine for 4 weeks or 8 weeks, then that is enough to achieve healing of the bone, and that is the only indication, the only case for non-operative treatment in unstable injuries. Otherwise, when there is unstable injury, it has to be stabilized surgically. So the three-column classification system of spine injuries is applied to the whole spine. Why the two-column concept of stable cervical spine? And there is actually more difference in stuff as I explained in alignments and so. The applicability and the reliability of the A or two-column classification for upper dorsal and lower number of injuries is questionable. We need to challenge that. Upper dorsal, the role of sternum and the ribs as a stabilizing device and surgical decision making, and the size and the strength of intervertebral disc that confers a quite different stability ideas to the lower lumbar. Subfasciate joints one side. Are we having work on concepts as I usually take that for stability? Probably we need to have more research about that. Again, some of these cases and how we stabilize them, I don't want to go for that. That's the case that again what doesn't mean unstable injury. This was treated in another country actually, and he was transported by plane to us. And that is how improper stabilization can lead to a significant deformity. And that's the conclusion. The widely accepted A or two-column classification system is applied to thoracolumbar junction injuries. The two-column A or classification system is less applicable to the more distal injuries at the upper dorsal and lower lumbar. At the upper dorsal, critical role of intact ribs and sternum is equally important to the spinal stability factor, and lower lumbar injuries, probably intact compression or tension side of the spine is enough to keep the spine stable. Are we having one concept at this anatomic level of the spine? Probably we need more studies, more research to see if I can.
Dr. Booth?
Yes, sir.
Step forward, Doctor. Einstein used to say, I want to make things as simple as possible, but not so simple that they're inaccurate. I think this is fine. Superb. Thank you. Any questions?
Very good question. So you don't use like MRI to estimate or to evaluate the ligamentous injury? Because when I saw, for example, type A, 4A, sometimes for me I prefer, or when I have first fracture, to do MRI. Then I see there is ligamentous injury or no ligamentous. This is help me make the decision later.
You see, now we have our threshold can obtain the MRI scan, especially when you work at a tertiary center. But on scientific basis, the rule of the MRI scan to make the decision is more or less limited in the thoracic laboratories. If you have doubts about the stability of the posterior, then yes, MRI will be helpful. But if we have, like, well, many of these cases, if you have widened, very clearly widened interspinal space, what the MRI will show.
Sometimes, for example, they're associated, there is hematome, or sorry, like, as I told you, like ligamentous, and if there is any associated, for example, lumbar inclination or something like that.
So I'm not against using the extensive MRI, which is more or less, as I said, now it's probably also diagnostic value. And cervical spine, the situation is different because there is a theoretical indication, because sometimes we say we need to have an MRI scan to see if there is a bulging disc, significant bulging disc on cervical spine.
We have someone coming, okay?
The reduction, we see that because that bulging disc might be elevated to the part of posterior visit. That idea is not really applicable to the thoracic lumbar spine. The thoracic lumbar, the indication of the MRI will help us to see if the injury is stable or unstable. If I have a clear evidence from CT and X-ray that the injury is unstable, I don't feel MRI will add too much dimension. I already take my decision.
Sometimes about ligamentous,
We can move on so we can get the last talk.
Yeah.
Fortunately, you guys have all afternoon to discuss it. So,
Yeah.
thank you very much.
No problem.
And excellent questions, of course, but.
No problem.
Yes, thank you. Dr. Booth?
Thank you. We'll shift gears to a different type of patients. I'm Ahmed Aboud, a neurosurgeon originally from Syria. I'm working right now as the director of Osama al-Mufti Neurosurgery Laboratory at Arkansas Neuroscience Institute in Little Rock. I have no disclosure. We all agree that see one, do one, teach one is not a valid strategy these days, and the OR experience alone is not enough to build a surgeon. So we need adjacent method to help with that, and that is simulation and training model. And available model right now do not give us all what we need. Virtual reality and computer models are great models. It can simulate everything, but it puts us in the virtual world. It's just like a computer game. It doesn't give us all the reality that we need. Physical models, good models, it can teach a lot of skills, but it's still far away from the real anatomy. Live animals, apart from the ethical consideration of using live animals for surgical training, even though it gives us the real situation during surgery. So watch here, dissecting the carotid in a pig in preparation for bypass. There is bleeding, there are pulsation, but it's a different, strange anatomy. It's like playing soccer in a basketball field. Human cadavers, great models, provide us with the real anatomy, but watch here, opening the sylvian fissure in a silicone-injected brain. There is real anatomy, but it's a dead, dry anatomy. There is no bleeding, no CSF, no pulsation, no real actions. So what we need, a training model that conveys a sense of reality to replicate live surgery by providing the anatomical characteristics and lifelike presentation and ability to breathe. And John Hunter is a Scottish surgeon of the 18th century, and I believe the Surgical Society at the UK named after him. He is the pioneer of the Hunterian ligation. He was the first to ligate the artery to treat a popliteal artery aneurysm. He said once that surgery is anatomy plus hemostasis. So we need the model that provides us with all these things. So we created the live cadaver model, the Aboud model, which is a cadaver-based model that combines the real human anatomy with the lifelike conditions of the living body. And simply, we cannulate the major vessels in a given specimen. We fill it with artificial blood, connected to a machine that provides a pulsative pressure, and when we use the whole cadaver, we incubate and connect it to a ventilation, and we can use the whole body, the head, the arm, the leg, and even just an organ. And these are the setting of the model, the connections, the setting of using the sensors. And just to show you a few samples, this is the head connected to the reservoirs and the machine, and you can see the realistic breathing. We need even to coagulate, but in this case we need to burn the vessels because there is no coagulation mechanism in the artificial blood and no vascular tone. Opening the sylvian fissure, releasing the CSF, and dissecting at the same as the surgery. We can even create pathologies. We create artificial aneurysms, ligate using a venous graft, ligate one side and suture it to a vessel, and this is making an MCA aneurysm, and here is the bulging pulsating aneurysm. We can create aneurysms in different types and different locations, and we put trainees behind the microscope, and the instructor be with them and give them instruction how to dissect the aneurysm and how to apply the clips to the right. We do this in different courses over the year. And these are some examples. This is an MCA aneurysm. This is a paraclinical aneurysm. So resident apply the temporary clip, dissect around the aneurysm, and practice how to apply the clip the right way. This is a PCAM aneurysm, and deep down a basilar tip aneurysm that we created, and I think this is the only chance for residents nowadays to clip a basilar tip aneurysm. Not only that, we also make aneurysm bleed and let trainees struggle with the situation and try to control the bleeding and treat the aneurysm. We create different scenarios, and this is, a million times to face this complication in a safe environment, in a model, than facing it for the first time in a live patient. You also can do angiograms for the aneurysm. This is a paraclinoid aneurysm, dissecting the aneurysm using the brain. Looking around the aneurysm, checking the ophthalmic artery, and we can detect using echodoppler in preparation of doing a bypass. This is ST, MCA, and anastomosis, and we can do all bypasses in all the vessels. Also, we can teach management of vascular injury. Here is using the temporal muscle, doing the tour hole, raising the flap, cooperating the meningeal artery, and here drilling the anterior clinoid, and while we are drilling, boom, bleeding from the clinoidal segment of the carotid. You can see the realistic bleeding, completing, taking the clinoid out to get some space and put the suture on the carotid and fix the problem. Also practicing management of injury of the carotid through transsphenoidal, making the injury, and let trainees struggle to controlling the bleeding in different scenarios. We don't have the sound. This is Professor Yazidi. He was so excited about this model, and he said it will revolutionize the entire thing. We can use the whole cadaver, and this is practicing management of retrohepatic vena cava injury. Also practicing management of carotid, dissecting the carotid, ligating the facial vein, And you can see how realistic and working on the same anatomy under the same condition during live surgery, creating the injury, the realistic bleeding from the carotid. Also, practicing coronary bypasses. Here we inserted the intra-aortic balloon to the ventricle, and you can see the bleeding and the flow in the coronary artery, and practicing all type of bypasses. We're practicing mammillary artery to coronary artery bypass. And we can create polytrauma injuries using the leg, practicing venous catheter and all type of venous access. The cost for the whole body is around $7,000, for the syphilis around $1,800, and the extras around $200 to $300. So it's not so expensive. We have published several papers about the preparation. We have a patent, and the model is recognized and cited in the medical modeling and simulation database of the American College of Surgeons. We do courses all over the year at the institute, and we can say the live cadaver model is the only existing model that combines the real human anatomy with the lifelike conditions of the living body. Thank you.
Dr. Ramadan, if you would join us. That was, my heart is still racing. Looking at all those complications, that is so realistic. So any questions at all? How long does it take you to shove a cadaver up? Half a day for each of the cadaver?
Yeah, I mean, 2 hours.
2 hours or so. That's after multiple, very good. Is that reproducible in other people's labs?
Yeah. Okay. And also, I'm ready to help whenever whoever wants such a model with them, just contact me and we can.
And then finally, one other question. Like for the carotid, we don't do carotid endarterectomies anymore. Do you do that? I guess you have to have the pathology of the carotid to do it.
Most patients and most cadavers, all cadavers, so you have some.
Thank you so much. Great.
Good morning, everybody. Difficult talks to follow, but I'll try to do my best to complete this on time. I was having a discussion with the trauma team during one of our trauma meetings, and with the facet fractures, their question was, why do you go sometimes from the front, why not from the back when you can see the fracture? And then, we are a group of 4 surgeons, so some of us preferred going from the posterior approach and decompressing. Some said, we do the anterior cervical discectomies and get good results. So that, along with some discussions with some past residents and fellows on cervical myelopathy, sort of gave rise to this topic about an optimal surgical approach and how I sort of make the decision on how to approach these patients. No disclosures, and the goal would be to discuss the nature of the pathology and the symptomatology which guides my approach. So we all deal with patients having cervical spondylotic myelopathy. We know that we're dealing with an aging population. By 2040, we're going to have about over 28% of the patients above the 60 to 65-year age group. And cervical spondylosis or cervical spondylotic myelopathy is going to be one of the major causes for progressive para or tetraparesis in a sort of gradually moving condition. We've got 20 to 63% of patients with DCM, and usually the history is a worsening function over 3 to 6 years, maybe longer in some patients. We don't know why it takes, for some, a few months, why it takes a few years for others, why they progress in a stepwise manner. But the natural history, when you look at a broad cohort of patients, suggests that myelopathy, once diagnosed clinically, usually progresses if it's from a compressive cause. So, as we all age, we have a cascade of degenerative changes. This results in compression of the spinal cord, and cervical myelopathy is a condition where there's spinal impairment from compression of the spinal cord and nerve roots. And that's why I've sort of combined this talk as an optimal approach for cervical myelopathy with possible radiculopathy, which guides my approach. Literature suggests that authors separate categories. Some consider pure degenerative situations such as disc, ligamentum flavum as a cause of compression, whereas others separate OPLL. I don't think there's a good way to separate these two issues because we see patients with a combination of all the above, and that's where we have to make decision making with the type of surgery, and that's where the art comes in. I think AI models may help sort of make some of these things, more algorithmic. When we have more data and we put more data in with imaging and sort of outcomes, it will sort of help us come to a sort of guideline with which we can talk to patients and make a decision. It's more common in males than females in the ratio of 2.7:1, and the average age of diagnosis is about 55 years. So the natural history suggests that there's a stepwise deterioration clinically, and it has a proven resistance eventually to all non-operative treatments. The dysfunction is at the spinal cord level, and when we see patients in the clinic, they come with progressive loss of dexterity, ambulation difficulties, spasticity, difficulty climbing stairs, which are most of the common symptoms. And if you have a patient in the 70s and 80s, you'd have noticed that they come and say, I thought it's related to my aging, which sometimes, is possible because patients get frail as they get older, but sometimes it is related to myelopathy. And it's essential that, imaging helps us rule this out. So when we look at cervical myelopathy, disc herniation, osteophytes, ligament hypertrophy, and ossification all contribute to pressure over the spinal cord over time. And it's a clinical syndrome that arises from a combination of these changes. This image is a sort of a nice representation. It shows the spinal cord where it's being compressed from the front and back, and a combination of changes where we see a little bit of osteophytes at C3-4, maybe compression from the ligamentum flavum, as well as disc degenerative disease. They all give rise to clinical changes, which we all know, the Hoffman's, ankylosing, spasticity, Babinski, and with the typical clinical symptoms of hand numbness, weakness, hyperreflexia, the scissoring gait, incontinence sometimes in late stages, and weakness and paresthesias. But one of the multiple big questions on this pathology. We don't know who's going to decline and when they're going to decline. So it's difficult to tell them now is the time to have surgery at times. There's no classification system to help us guide, the direction which we want to treat patients with, whether it's non-operative or operative immediately. Do we include OPLL in this particular situation? And the term spondylotic myelopathy is sort of taken a different transition to a degenerative cervical myelopathy, and I tend to include radiculopathy into it because sometimes you get patients who have pain, which is the main symptom, radiating down their arms, along with the weakness, numbness, and other myelopathic clinical signs. And how do we deal with these changes over time, and how do we correlate this with image findings? These are all the challenges with simple pathology, which has a very effective surgical treatment. When patients come to our clinic sent by the neurologist, sometimes it's not all about myelopathy. There can be differentials which we need to think about, including demyelinating disorders. Vascular disorders could occur which can cause similar clinical symptoms and signs of myelopathy, motor neuron disease, spinal cord dysfunction, and we have to keep in mind all the above while thinking about patients that we're going to treat. We have low motor neuron pattern of diseases such as drugs, alcohol, metabolic disorders such as vitamin B12 deficiencies, which can all cause similar clinical symptoms and signs. And of course, with any clinical patient, we image them with x-rays, which provide us with some information. If we think that there's a deformity, we get Scoli series to identify whether the deformity is fixed and flexible, and all this helps in our approach to treating the patient surgically. CT scans are a really good tool to make out bony anatomy, and as patients age, we can also identify osteophytes, OPLL, in addition to bridging bone autofusions, which will help direct our approach. And of course, MRIs ultimately have defined the anatomy. They help us identify T2 changes. They are high resolution. They help me identify whether I approach the patient on the front, the back, or sometimes a combination of approaches. And of course, if there are other causes that are causing a myelopathy, such as tumors, demyelinating lesions, fluid collections, an MRI is essential to rule all this out. MRI findings of significance in myelopathy are the presence of T2 changes, edema, which indicate demyelination or Wallerian degeneration, and of course the T1 changes, which are more predictive, such as cavitation or neural tissue loss, in terms of outcome and our discussion with patients on outcome. Each patient responds differently to the type of treatment, and so clinical judgment comes into it, a lot of it, and of course the type of patient that we're dealing with, their comorbidities, and guidelines which help us direct treatments. The treatments are usually tailored individually, depending on the location of the pathology and the number of levels. And there are many factors which help identify outcomes. There's a disconnect between what sometimes we see and the outcome that we obtain. Some patients do really well with an improvement, whereas some patients just remain static and neurologically stable, which is an important part of the discussion with patients before we take them up into surgery. But one of the most clinically important indicators before taking a patient up would be the amount of disability or dysfunction. And a good measure is the Japanese Orthopaedic Association scale of function of the hand, the lower extremities, and the ability to ambulate. Individuals' vulnerability to myelopathy is variable. Sometimes we see patients with T2 changes in the cord who do really well, and sometimes we see patients who decline rapidly. So genetics, age, other adaptive mechanisms, nutritional status, all sort of play an important role in the outcomes with patients with DCM. So the best outcomes we see are those who have a younger age, milder preoperative myelopathy compared to those who have a severe myelopathy, non-smokers, fewer comorbidities, and if gait is not significantly impaired, along with a shorter duration of preoperative symptoms. They tend to have the best outcomes, and there's an earlier recovery to their neurological symptoms and signs. And of course, guidelines based on publications help identify patients for surgery. If they have severe orthopedic association scores, they are an indication for surgery. Patients who are on the cusp would can be watched and waited. And there are others who are asymptomatic, and you can just follow them up clinically over a period of 6 months, a year, or a few years to see if they progress. Eventually, it's almost always a surgical problem, and 20 to 60% of patients usually decline 3 to 6 years from the diagnosis. Asymptomatic patients with cord compression could develop symptomatic myelopathy at around 8% a year. And so at 4 years, about 25% of those patients are going to have a clinical myelopathy, which most likely will require surgical intervention. And I'm sure you've all seen patients in your practice where they have disproportionate compression of their cord. They look clinically well, but maybe 6 months or a year or 2 years down the line, they've had a trip or fall or a whiplash injury, and then they come with central cord syndrome. And so it's a difficult decision. Do I prophylactically do surgery on these patients, or do I wait, watch? And that's something to decide along with the patient. The treatment options, non-operative, which would include sort of tractions, pain management, physical therapy, intermittent soft collars, anti-inflammatory medications, the series of steps which were shown by the prior speakers in these situations. Some have tried home exercises, neck bracing, and of course immobilization with orthosis. But we don't do this for a long period of time, as it's not beneficial, and in fact may be detrimental as patients lose some of the strength of their cervical musculature. So going on to a few representative cases which would sort of guide my decision making. The first one is a 71, and this is going to be open to the audience, so you can also chime in. A 71-year-old male with right arm and hand weakness for 4 months. Grip weakness or worsening with progressive imbalance, no radicular pain or cervicalgia, not much neck pain, but just bilaterally gripped, Hoffman's positive, brisk reflexes, positive rhomboids. So this is his imaging, and you can clearly see that he's got some anterior compression, posterior compression as well, mostly at C3-4, a sagittal image, and then an axial image across there. This is the patient's CAT scan. It shows significant spondylosis, C3 to C6, with narrowing at 4-5 and 5-6 and an anterior aesthesis. So the question is, what would you do?
What's the exam?
Myelopathic, mostly brisk reflexes, gait imbalance, and weakness.
You have a level hyperreflexic starting, you know?
Yeah, C4. Yeah, around C4. Brisk
Can we go back to that image again?
I go from the front of your 2 levels, and I tell, and I refuse as opposed to this replacement.
Okay.
2 levels on the front.
I also the same.
The same?
I would feel just like from anterior approach.
The front, okay.
Perfectly reasonable to go from the back, perfectly reasonable to go front.
And that is the situation. It is perfectly reasonable to go either way, you know.
I would do posterior only.
Posterior. That's what I ended up doing, because he didn't have any radiculopathy and he was clinically just myelopathic. So I did a C3 to C7 decompression fusion. Again, the question is, how high do you go? C2, T2, you know, some of my partners always love C2 to T1s or T2s. There's no good answer. Literature is very variable. You can stop at C7, sometimes less. In his situation, I thought that, you know, compression and clinical symptoms warranted going down because he had hand weakness on the exam. So I stopped at C7.
You did pedicle screws in C7?
No, I did parts screws, yeah, lateral mass screws, yeah.
But there is 2 questions. First of all, which one is better to restore the alignment? Another thing, does the patient have axial neck pain?
Correct.
So this is to go anterior, which I prefer, you know, to restore the alignment and to a little more also if the patient has some sort of axial neck pain.
Both are good. Both are very good points. In this particular patient, he didn't have axial neck pain or radiculopathy. And the other thing was, I thought his lordosis was adequate. He didn't have much of a straight spine, about 10 degrees of lordosis, and he didn't have kyphosis. So I thought it was a fair approach to go from the back and, you know, help him with the myelopathy. Clinically, at 1 year, he is doing better. His myelopathy has improved. Neck pain, not much. You know, for whatever reason, I find that an older subset of patients above their 60s do better with either anterior or posterior surgery, and they tolerate pain and recovery better, you know, compared to the patients in the 40s and 50s who have done the same posterior surgeries for. I'm not sure why, but they do well. This patient did well clinically. So that was my choice. And again, both are reasonable and important considerations, as I'm going to show you in the next case. Yeah. The second one, similar findings. Okay, I'm just going to jump to the images. In this particular patient, higher BMI, he had core changes at C45 and had been told he needed surgery on his neck before. He's been walking around with this for a year or two, progressively worsening with gait imbalance and instability, hyperreflexia. Again, not much pain, no axial neck pain, no radiculopathy. What would you do for this one? Anterior only?
Posterior only.
Okay. So this is his CAT scan. He had a congenitally narrow canal as well, you know, about 9 millimeters at multiple levels with some disc disease. He is almost a straight spine, maybe mild lordosis was maintained, and a good really good neck motion. So I ended up doing a C2 to T2 for this one with a wide decompression, C3 down to C7 for his myelopathy, because that was his main symptom. He did well at a year and a half. These patients have almost all been followed up for about 2 years. I'll go to the next case. So this is a 68-year-old with progressive myelopathy and a C6 and 7 radiculopathy. This patient had, this was one of the cases I did with my partners. He had a huge disc which went behind the vertebral body. And the question was, what do we do? A 2-level discectomy versus a corpectomy? was the front back if a corpectomy is done? What would you as the audience do? Two-level discectomy, yes?
How's the CT?
Do you have a CT?
No, I don't have a CT.
I mean, might go with just the ACDF.
It was a soft disc, which I found.
Because I can't tell, but from CT might
Yeah.
be more.
So I think the lower one is less automatic. So this is what I prefer to go after that one first.
Okay.
And do it and see the patient how he does.
Okay. I would agree with that. I would have done something with the two-level ACDF and taken out, because this is a soft disc. The CT scan didn't show an osteophyte, but you know, it wasn't my patient, and we finally felt that a corpectomy was a better approach. So this is what we ended up doing, a corpectomy from the front to get the disc behind the vertebral body. And I back up most of my corpectomies. I don't know what everybody else in the audience does. I think outcomes are much better when they are backed up, irrespective of whether it's 1 or 2 levels. We did not back this patient up, and at around 5 months he had subsidence. He had other comorbidities. He's a diabetic, you know, higher BMI, and he had cage subsidence. At this time, you know, we discussed it again, and my partner wanted to know what we could do. I wanted to fuse him prior to this, but he decided to watch and wait. And the patient is doing clinically well. No myelopathy, the x-rays are stable, no changes, and this is about a year out from this. Finally, a 55-year-old male with myelopathy and multiple comorbidities with some core changes at C3-4. No osteophyte or OPL at that level. Yeah, I just did single ACDF and he did well for a case like this. No big surgery. Being 55, you know, sometimes less is more and sometimes more is better. The question is, we don't know when which will work, and always tell the patients that, you know, things may change later. 68-year-old male with rheumatoid arthritis on methotrexate. Again, osteopenic on the bone density, myelopathic with symptoms. Multiple levels of compression in this situation with a loss of lordosis at C4 to C7. This is MRI and this is X-ray. He's had prior cardiac surgery, multiple issues going on. Lots of disc height at 5, 6, 6, 7, and the scan showed some osteophytes posteriorly. In his situation, what would you do?
Three-level ACDF.
Three-level ACDF?
That is what I would do.
Okay.
Is osteoporotic?
Osteopenic, but he's on methotrexate, rheumatoid medication. He's been on steroids on and off for multiple years for his rheumatoid symptoms. So
I'll do 3-level ACDF and watch it over a couple of months. If there's any like subsidence, I'll pick it up at that time.
okay, which is all are fair and good options. I decided to do a corpectomy at those compressed levels because it looked like those bone on bone at the 5, 6, and 6 level. Those are tough discectomies to drill through the bone, and sometimes the drilling gets a bit more because there's no end plate which is clear. So I just did a corpectomy at the level and then backed it up, decompressed him widely from the front and back. You know, the reason for this is also that he's on methotrexate, on steroids. I've seen subsidence with anterior discectomies in these patients, and they don't really do well. He had significant canal compression, so I thought a circumferential decompression right up front is a better method of treating him, because he's got multiple comorbidities as well, and didn't want to put it through repeated surgeries. You know, so this was done the same day, one stage. That's how. You know, yeah, go ahead.
No, just I'm looking at the X-ray, the C2 screws, like they are not aligned with the others. Was it like I think that just was transverse, or was the pedicular screws?
They are pedicular screws, yeah, and they ended up being more lateral compared to the other screws.
I mean,
so I had to put a cross connector and connect them up. Yeah.
Okay.
So most of the time I use navigation for the C2 screws. So they were sort of off to the side ultimately, but they were in good location. Yeah, no issues. Patient again did pretty well. So in deciding what approach, you know, expectations need to be clear. The primary goal needs to be prevention of worsening of neurological status and hope for recovery. Those are the things that I talk to my patients about, which are important, because if their expectation is to start, running sometimes, or getting up from their chair immediately, or their wheelchair, or walking from a myelopathy to walking without the walker, those are difficult goals and expectations. So a clear set of expectations of the patients. Selecting the right procedure when kyphosis is present and 50% of canal compromise, have to make a decision on the anterior and posterior approach as well, along with comorbidities. They always have some sort of accompanying deformity, so consider surgeries or full spinal scoliosis series if that's one of the issues that you're thinking about. And then to conclude, sometimes non-operative treatment may be the best option, especially in frail patients who have too many comorbidities. You don't want to necessarily make them worse, and then clear discussion with them helps. Cervical traction, other methods may be helpful as well. The medical treatments can be rigorous, non-rigorous. We call rigorous when we do much more, especially in the younger subset of patients around the 60s or early 70s in good condition. The non-rigorous would be for an 80-year-old myelopathic who comes in, with physical therapy and other modalities. Then anterior and posterior surgery both work well. Laminoplasty versus laminectomy, another discussion, which we should take another talk. But again, clinically, both work well, depends on the patient. And finally, ACDF versus scopectomy versus hybrids. All are acceptable. There aren't any particular guidelines if you look for something, whether it's a NAS or CNS. It's the clinical condition, the clinical symptoms, and the patient's comorbidities which ultimately have to guide you, and what's best in your hands. So.
Just in a matter, just because we are getting so close on time, might as well hold questions, but I just really want to thank you very much and appreciate the fact that you came out. I look forward to seeing you next year when you solve the laminoplasty question. So medical